Our next panelist is Brad Guest. He's a partner and co-founder of Subsidium Healthcare. He's managed critical strategy and implementation projects for multi-hospital systems, including the management of market and financial analysis and collaboration with both client and senior management and physician leaders. Brad received his bachelor's, master's, and JD from the University of Texas. Brad, we welcome you.
I'm really honored to have been asked to speak here. This initiative is one that I'm pretty committed to and invested in because I've worked on it. I was honored to have been able to work with Bob Hess and the others from Newmark on the original study. So many people were involved in that. And really, I think when people say that it's unique, it's for a reason. I think tying it to economic development is one of those simple ideas. And like many simple ideas, it's also a rare idea. But that's one of the things that's really been great about this. So the opportunity to come back and give what I hope is a national perspective. I'm from Texas, maybe I should join in the theme there, but I live in Georgia now. So just very briefly about my background. I'm with a firm called Subsidium Healthcare. We do a lot of things, but my own practice area is management consulting, mostly for health systems. So I'm on the provider side, or the bedside side, if you will. As Bob said in his remarks, healthcare is so broad, it's mind-numbing, really, in terms of the numbers of things that are in it. But I'm in what you would traditionally think of: the bedside, the office clinic, dealings between physicians and hospitals. And so I think that's a pretty important perspective to have, and it'll really be at the core of what I'm going to talk about today. And then the last piece, highly skeptical but not jaded. So I think it's easy to get jaded, I think, sometimes, but when you see initiatives like this, and at least the will, if nothing else, the will that is so evident here to do something good, I think that's one of the great things that kind of keeps you charged up. So in the very brief amount of time here, I'm really going to do three things. First, I'm going to outline a challenge or a problem that's occurring. And then second, I'm going to suggest a response to that. And then thirdly, and actually tying to some extent on the remarks from today, I'm going to suggest a way that this response in Mississippi could actually happen. It's just an idea, it's nothing more. So I'm going to start with the problem. And when I flip to the next slide, you're going to see maybe one of the best quotes you'll ever hear, or at least I think it is. And you'll also see one of the least glamorous photos that you've ever seen. So with that intro, that charming gentleman on the right, does anyone know who Herbert Stein is? He was an advisor to President Nixon. So never one for the Hollywood look, Mr. Stein. But what he said is great. He says, if something cannot go on forever, then eventually it will stop. Right? Truer words were never said. So I'm only going to show a few charts, and the chart below is the national health expenditures. So for the most part, these bars represent sick care. Almost 100% of that is sick care. And to make it really real, as we just heard before, if you just do what your grandmother says, over the long term, a third of those bars would disappear. That's how big prevention is. So what people have pointed out is that this escalating growth in sick care is eating up a bigger and bigger piece of our national pocketbook and our individual pocketbooks. So then the comma comes and people say, all right, it can't continue. Well, if it can't continue, then what has to change? So this is the problem that I wanted to highlight. And then the responses to it are really about innovation, and from my perspective, sort of from the provider side. So as the previous comment said, everything is going to change about healthcare. That's probably not an overstatement. That's probably exactly right. So these are just some of the areas. Data. We have so much more data and better better ability to use it. Processes, how care is done. Patient engagement, feeling connected to the healthcare system and using technology to do that. The continuum of care and all the technology to make this happen. So these are the things that are going to be in play. So innovation, and I think we're going to overlap somewhat in our comments, which is good, actually. Innovation means to renew or to change actually from within. So people sometimes think of it as this creation of a wholly new idea. While it can be that, it can also be taking something that already exists today and tweaking it, making it work better or in a different way. It's important to keep in mind. So here's where we are today, and I'm not going to try to get into all the nuances of this, but this is a well-used slide that a lot of government policymakers use. So just think about the left hand and the right hand, and don't worry about the middle or the complexity of it. On the one hand side, we have uncoordinated care, and that's mostly what we've all known in our daily lives. That's where we are. We're trying to move to something different. So uncoordinated care, or in that world, how does coordination happen? It actually happens the way Bob Hess said when he mentioned his daughters. And I've spoken with Bob many times about that experience. And he's taken the time to find physicians that are specially skilled in what his daughters need. He takes them to where they're located. He's very up on the medications, all the things that any father would do. So he's acting as that point of communication or coordination. The same for the governor when he talked about his dad, or for Dr. Hayes when he talked about his mom. That's the way it's happening today. But not all of us are as well able as those individuals to do that. Some people don't have the money, they don't have the education, and they fall through the cracks. So that's the system we have on the left. Moving toward the right, really health systems and physicians are involved in trying to put together processes that weave all of this together sort of for you, behind the scenes, so that you don't have to wait until you're sick to go to the doctor. Maybe the doctor calls you because he went to medical school, or he or she, and they know which things you need to be tested for. They know which things to observe to see that a problem may be coming down the pike. So that's a very simple explanation, but that's really what has to happen, because as we heard, a third of all the cost is wrapped up in prevention. So how will that happen? That's still, I think, a point of great debate, whether or not national standards are the answer, or if it's going to be more of a regional or even local type initiative. My own view is that healthcare is what you might call stubbornly local. It has this stubborn nature where things either work or they don't work because of the culture, the medical staff, and how they're situated, how they're composed. And I think things have to work in a local way, although drawing upon national standards. So let's take an example. One of the big and sort of crazy that it happens things in our healthcare system is that we have this radical drop-off in care after 5 p.m. and on Saturday and Sunday, right? I mean, the human body doesn't recognize the clock. It doesn't recognize the calendar. You get sick when you get sick, but our whole system is not set up that way. And so this chart is just simply to say that there are differences. I mean, other countries have designed their systems in a way that you do have a true coordination of care across days of the week and across hours of the day. Now, we don't have to adopt any of those countries' approaches to do this. This is something that can be done and should be done through health systems, working with their employed medical groups, working with urgent care locations, information technology, so that it's a coordinated approach. But again, how that happens will vary by city, vary by market. But that's the type of thing, as basic as it may sound, that really does need to occur. This is just one example of from the within, from the inside innovation. So as we talk about innovation, this was from the Harvard Business Review in 2006, an article just sort of complaining why in the world is innovation in healthcare so hard. So in 2006, these same issues were being debated, and I think it's probably even harder now in some ways perhaps easier, but it's maybe harder today simply because the complexity level has gone up and the scarcity of funds is even tighter. So my point simply is that this is a known challenge in our industry, and I think we're at the point now where a lot of innovative ideas will be coming out. So let's talk about that. I wanted to give an example. So everything up until here that I said was the problem. That was the problem. So one of the responses is how local communities can put together people, capital, ideas, all the things necessary to allow innovation to flourish. So I wanted to highlight for you the LG, which stands for Lafayette General, the Lafayette General Innovation Fund. It's brand new. I think in some ways I'm kind of inadvertently making their public announcement for them as I came to find out. But my organization, Subsidium, has relationships with some of the hospitals in Louisiana, and so we got introduced to this fund. So what is it? They have a great-looking website, that's for sure. The LG Innovation Fund was started by Lafayette General Health System. So that's as local as you can get. A small community in a state not at all dissimilar from Mississippi. And that health system has grown a lot. It's been operationally very efficient. It's done a great job. And their CEO decided that they needed to do something to provide good, rich, fertile potting soil for innovative ideas to blossom. So they put some money in the pot. Nothing starts until somebody puts some money in. They put some money into the pot. And then they also partnered with public-private entities. So their version of MDA and MEC and different organizations like that got involved. And that further increased the resources. And then very importantly, they connected with a college. So in this case, the University of Louisiana at Lafayette. So their big idea is that you can come to us for multiple things. If you need money, they don't have a ton yet, but they have money. So if you need money to seed an idea or to invest, they can do that. Similarly, if you need a place operationally to get started, they have a place for you to do that, sort of like a business park type concept. And then thirdly, maybe most important, they offer an in-house proving ground. So if you're doing things clinically or in the service side of it, and you need to show proof of concept, Lafayette General is going to allow you to do that. So Dr. Hayes can come up with a process, a technology, a product, and have the ability to use it in a real-life setting and see how it works and show efficacy. It's not like a clinical trial. It's not that structured. But the idea of having all those things tied together, that's a really compelling idea. And there's no reason why something like that could not happen, not just once in this state. It could happen multiple times. You could very easily imagine something like this happening because it draws, as I said, on the will that's so evident. And there are numerous institutions in the state who I think could play some of those roles. So, yeah, as I said, it's an emerging area, an emerging organization. Their focus areas are on cost savings, revenue generation, improved health outcomes, patient satisfaction, and employee satisfaction. I went ahead and listed the executive director's name if anybody's interested. So that's just an example. And in the remaining 43 seconds I have, I wanted to suggest a way that something like this could make a tangible impact here. This is just an idea that really came from some of the remarks that others had made. But one of the things that the healthcare industry is struggling with is coding, which is how I even see heads nodding, and that's not usual for a coding conversation. So one of the big issues is how do you put a pricing code on all the stuff we do? Well, it turns out that America is in the midst of shifting gears in coding from one system to another. So already today, it's a big problem. But as we shift to this new system, which is happening right now, it'll go into effect next year, the complexity is going to go through the roof. And so it's already a shortage area to find medical coders, and it's just going to get worse. So why not? Here's just the idea. Why not have a public-private partnership similar to the LG Innovation Fund, where you have a local college that either creates or expands their medical coding program. Maybe the state somehow gets involved or some public organization to help get students initially involved, run them through this program, and at that point, a job offer is almost 100%. And so I need to conclude, but that idea of bringing academics together with public, private, and serving an existing need in the healthcare industry, that's where it's at. So I think that's just one example, and there are many, many others. But the key to it, as we've said, is just having the leadership, which I think we're very fortunate to have. And very soon, I think we'll start to see tactics that can make this even more real and more tangible. So again, I thank you for the opportunity.